Hi there, Dr. Terry Schoenfeld for UAB Department of Medicine. In this installation of videos on reducing perioperative cardiac risk, I'm going to talk about the data on beta blockers. So this figure shows the pathophysiologic cascade thought to explain perioperative myocardial infarction. What you can see right here is that the stress of surgery can increase blood pressure and can increase heart rate. And we certainly know beta blockers can mitigate this. And they have been shown in coronary artery disease models to reduce recurrent myocardial infarction. So it makes sense that if beta blockers can reduce heart rate, can improve blood pressure, that leads to less myocardial ischemia, they should be able to reduce perioperative MIs. But does this bear out when you look at the data? One caveat, there is a series of studies called the decrease studies that were produced by a character called Poldermans. And unfortunately, many of these have been discredited as shown in the right side of this table. So we've lost a large body of data in the perioperative world, especially on beta blockade. So we got to keep that in mind. So there have been two recent systematic reviews on beta blockers, and they both have basically shown the same thing. One by Burri and colleagues that was published first, and then with the recent updating of the ACC-AHA guidelines, a systematic review was commissioned on beta blockers. And I'm going to show both of them for completeness sake, but really the answer is going to be the same no matter which group you look at. So Burri and colleagues did a meta-analysis on what they called the secure trials of beta blockers in the perioperative period. And secure means not the decrease studies. And they also only included studies felt to be scientifically valid. And what you can see in this top figure here, and this is a pretty standard look at a systematic review. You show all the individual studies, you show event rates here. You'll show the results of the studies numerically and also graphically. And these squares are the point estimates from these studies. The lines coming out of the 95% confidence intervals. And the size of the square is the weight of that particular study, with larger studies getting greater weight. And then finally, the summary of all these studies together is this diamond. The peak or middle part of the diamond is the point estimate. The sides of the diamond are the confidence interval. And what you can see here is that mortality is increased by patients who are randomized to beta blockers by 27%. You can see the confidence interval. When you look at the bottom and include the decrease studies, which really is in this case fabricated data, you can see there was a suggestion of a reduction in mortality, but I'm not sure we can use any of this information. I put it here just for completeness sake. The recent ACC-AHA systematic review showed the same thing, that mortality was increased in patients on beta blockers perioperatively. So non-fatal myocardial infarction, though, was reduced. And you can see here that it was reduced by about 27%. And there's a confidence interval. So that's a good thing. And the ACC guideline systematic review showed the same thing, that that non-fatal myocardial infarctions were reduced by perioperative beta blockade. Now, what about strokes? Unfortunately, strokes are increased by perioperative beta blockers up to 70 or around 73%, but could be up to 199% increased, which is unfortunate. And we also saw the same thing with the systematic review done for the ACC guidelines. The strokes were increased by about 86%, but could be up to 216% increased. And this is data or a table from the POISE trial that shows the outcomes of perioperative myocardial infarctions and strokes. And the bad thing you can see is that more patients had strokes who were on metoprolol than on placebo. And these strokes were pretty bad. Patients were totally incapacitated 26% of the time, or needed significant help just to do daily activities 30% of the time. So while we focus on stroke, though, in these studies and talk about the increased risk of stroke, what is important to take home from this is MI, though it was reduced by metoprolol compared to placebo, there were many more MIs than there were strokes. So even though we focus on stroke, myocardial infarction is a much greater risk of outcome and is going to occur more frequently, even though it is reduced in patients on the metoprolol arm. So keep that in mind. So in general, if beta blockers don't help the average patient in these studies, do they help those at high risk? So we might expect that the higher your risk, the greater the benefit you might get if you have some benefit at all. So this is what's called the Lindenauer data, and he looked at the effect of in-hospital use of beta blockers on in-hospital death in patients based on their Lee criteria, the revised cardiac risk index score. And the higher the score, the greater the predicted cardiac risk. And this was a very large cohort of patients. Now, it used a managed care database, but it did have over 300,000 patients from 329 different hospitals undergoing major non-cardiac surgeries. So what you can see is patients who are at low risk that have RCI scores really 1 or less actually had harm in this propensity matched model. They actually had greater risk of death if you got a beta blocker than the patients who are at higher risk. So high risk patients had improvements in their risk of death in this particular observational study. Now, there are limitations to this study which you need to know about. There is risk of residual confounding because some of these things couldn't be controlled for because it was a database study. Specifically, they didn't know the date of surgery in this study, so there's no real way of knowing the time of beta blocker usage relative to surgery. They didn't know the indications for beta blockers, and they didn't know if beta blockers were actually used preoperatively. And they also didn't know if patients who weren't on them just had them stopped preoperatively and had been on them a long time or not. So there are some limitations, but certainly a suggestion of improvement in in-hospital mortality in patients who are at high risk. London and colleagues also did a retrospective cohort study trying to evaluate the effect of beta blockers on mortality in vascular surgery patients. And they used a VA Surgical Quality Improvement Program database to study over 136,000 veterans undergoing vascular surgery from October 2005 through September 2010, so relatively contemporary. On the bottom of this figure, what you can see is that it really didn't matter if patients who are undergoing vascular surgery, it didn't really matter what their RCRI score was. Again, the higher the score, the greater the risk. So patients really gained no benefit in undergoing vascular surgery by being on beta blockers. The top, though, showed a similar findings to what Lindenauer found, that higher risk patients seemed to gain benefit from mortality, whereas low risk patients didn't gain any and had a suggestion of increased mortality. But this too is an observational study and has limitations of what confounders can be controlled for. So what about a randomized control trial in this setting? So this is the POISE study, which is the largest study to date of beta blockers, and there are limitations of how the POISE study was done, which has been well documented. But what this shows is this figures the subgroup analyses from the POISE study. And if we focus down here on the bottom, what we can see is that they broke up surgeries into vascular, orthopedic, intraperitoneal, and others. And you see a suggestion that maybe vascular surgery patients do benefit in getting perioperative beta blockers, but the interaction test was not significant. So even though it sort of looks this way, that vascular surgery might gain some benefit, they really don't. And these confidence intervals all overlap, and the confidence intervals are these lines coming out from the box. So no definite benefit in vascular surgery patients being put on beta blockade. And interestingly, at the top of this figure, the POISE patients were broken up by their RCRI score. So again, the higher the score, the greater the risk. And we don't see that relationship like we saw in those previous two observational studies where higher risk patients gain more benefit. Here, actually, higher risk patients seem to be at greater risk of harm, and lower risk patients might gain some benefit. But again, the interaction term is not significant. So we can't really draw any firm conclusions from this study. So the recent American College of Cardiology updated guidelines in August of 2014 suggest the following. So if beta blockers should be continued in patients who are on them chronically, and this is a class 1 recommendation, which means benefit greatly outweighs the risk. A class 2 recommendation means that benefit might outweigh risk, but we really don't know. Studies can be limited. And what they recommend is that it's reasonable to begin beta blockers in patients who are found on preoperative testing to have intermediate or high risk of ischemia. Now, one thing you have to keep in mind is if these patients are at high risk of stroke, you might not want to do this, or if they're in bad heart failure, you might not want to initiate beta blockers. It's also reasonable to initiate beta blockers in patients who are at high risk, have high RCRI scores greater than 3, and that's what we saw in the Lindenauer and London data, that it suggested that these patients gain benefit. They go on to suggest that if you do start beta blockers, you should begin them greater than 1 day prior to surgery, and they actually recommend against beta blockers being started on the day of surgery. This is a class 3 recommendation, means it is harmful. Now, if you do initiate beta blockers, you really should shoot for a heart rate of in the 60 to 70 range. And you also should not initiate them unless systolic blood pressure is at least 115 millimeters of mercury. And this should also be sort of the floor that if you do start beta blockers, you really don't want to go below a blood pressure of 115 to 120. Remember, anesthetics are cardiac depressants. And it's thought that one of the things that happened in the studies that showed increased stroke is that beta blockers led to too big of a reduction in blood pressure, especially after getting anesthesia, which this led to reduced cerebral perfusion and stroke. So you want to give patients a little bit of cushion room with their blood pressure and being on a beta blocker. Again, just like the American College of Cardiology recommends, start them at least the day prior to surgery, if not longer. The longer you can start it before surgery, the greater the chance you have of making sure that patients tolerate it and that there won't be significant side effects. Now, how should you titrate beta blockers? Well, we don't really know too much. The data is fairly limited on this, and the main titration studies were the decrease studies, which have been largely discredited. And one of the things if you look at the beta blocker studies, many of the patients once they got to surgery were on their initiating dose of beta blockers. So we're not quite sure how best to titrate beta blockers preoperative. Again, I think you should shoot for a heart rate of 60 to 70 and blood pressure of 115 to 120. And which one should we choose? Well, we don't really have great data to support one beta blocker over another, other than to say that the POISE study suggested that initiating a long-acting beta blocker on the day of surgery certainly is harmful. So we definitely don't want to do that.